diabetes educator, Wendy Arnie, dietitian. Tonight's session will be recorded. Might just go on to the welcome to country. So I'd like to begin by acknowledging the traditional custodians of country throughout Western New South Wales and their connections to land, water and community. I pay respect to elders past, present and future, and extend that respect and a warm welcome to all First Nations people present today. Just some brief housekeeping reminders that we need to maintain patient confidentiality at all times. We live and work in small communities and sometimes it's easy to identify people accidentally, so just extra care for that. Tonight's meeting is recorded. We ask you to please remain on mute except when speaking. Encourage all participants to turn on the webcam, make it feel more like we're together. If you're able to, you can ask questions by raising your hand and talking, or you can type your question into the chat if you don't feel like turning on the microphone. We're always happy to hear your voice. There will be an evaluation at the end of the session to complete, and a QR code will be put up. And we'll also have another QR code and link to health pathways, which we'll talk about a bit later. As always, a reminder that the words that we use to talk about diabetes affect the physical and emotional health of people living with diabetes. It also affects how people in society view people living with diabetes. Our words need to show that we care and remove bias and blame. So people with diabetes may call themselves diabetic, so why shouldn't I? Well, evidence shows that 1 in 2 people find the label unacceptable and 1 in 4 find it harmful. People with diabetes are free to use whatever words they wish. However, other people, especially those of us in healthcare, have a responsibility to engage all people affected by diabetes in positive and helpful ways. So with that, we'll pass over to Dr. Madhuri Velagala, who will present about abnormal nutrition, alcohol consumption in type 2 diabetes.
Thank you, Alex. Welcome everyone and a very good evening. And I'm just going to share something about the alcohol consumption and type 2 diabetes that we all have challenges sometimes to handle. And as you know, I work in Davo and I call Davo home now, and been here for more than 10 years, working as dietitian and diabetes educator. And today's topic is something we call abnormal nutrition because of the abnormality in the intakes. So let us go through the session, as I got 15 minutes to do this. Yes. So if we look into the statistics with alcohol in Australia, the key findings are more about the availability. And when there is a good availability of it, there is a high risk in drinking. And once there is a high risk in drinking, it is causing ambulances to attendance, and the attendance is getting very high these days. And also the hospitalization, death rates, and the treatment episodes are getting higher everywhere. These are just numbers and figures that you can also get it online, but it's very interesting to see the statistical impact that is from starting the age of 14, which is like very hard to accept for a parent having the kids going through this risk of excessive drinking. Next one, please. So if we look into the guidelines for alcohol, and HMRC guidelines state that alcohol-related diseases or injury for a healthy woman or a man should drink no more than 10 standard drinks a week and no more than 4 standards on a one day. So this is the actual guidelines or a standard for a healthy person. And if we look into the latest release on alcohol consumption, the statistics from 2022 analysis have showed that there are more 1 in 4 adults are exceeding the alcohol intake in adults up to 26.8%. Male are having likely more than the female to have excess in intake of 35.8, and more than 1 in 3 young adults aged 18 to 24 exceed the guidelines up to 36%. So this is not small numbers when we look into the intake and consumption alarming. So if we look, the normal healthy person has these guidelines to follow and it's challenging. So what will be the impact if it is having a comorbidity of a diabetes identified? So we'll just go to the next slide. Thank you. So the risk alcohol consumption, according to National Drug Strategies of Household Survey, say that if a person is having more than 10 standard drinks of alcohol a week, or more than 4 standard drinks in a single day, at least once a month, that is called risk consumption. That's statistically how they take it into research for things as a breakdown. So if we look into diabetes and alcohol as a topic today, into the next slide, please. Yeah, so there is something called alcohol concentrations. So according to Australian New South Wales Ministry of Health in 2017, it has been clearly identified the alcohol concentration varies in a beer from almost 0.9 to 6, wines from 12 to 14, fortified wines around 18 to 20%, and in spirits from 40 to 50%. And if we look into what is a standard drink, I don't have to go into the details, but I just want to focus here on the carbohydrate content, which is more diabetic related, just to give you an idea. So in a light beer, it's 6, whereas in the full strength, it's 13. And sparkle wines can be around 3.5. And normal alcoholic red wines around 100 ml have got 4 grams. These are the values based upon the standard drinks that are found in the apps. And this is just an average to understand. When it comes to spirits, they may not have much alcohol. It's a cola or the tonic that they add into a standard drink. When they're adding a specific amount of a cola or a tonic, it's getting 15 grams of carb into it. Other than that, cocktails may vary from 0.4 grams to almost 37.89 grams of carb in a drink. And the main emphasis when we're talking about alcohol and the nutrition value, I just put like a small panel there. The focus is on the calories, which we'll be talking in detail. And the next one we're also talking about there is the carbohydrate. So if you really want to guide someone about the quantity, about how much to drink, how to calculate their standard as a teaching tool, there is a link that is there from the yourroom.health.newsouthwales.gov.au, and it's a good resource to self-reflect as well about the quantity and how much is the standard that it's coming, because glasses come in different sizes and shapes. Next one, please. Thank you. So if you're thinking about alcohol, the first question is, what should we say if a diabetes client comes into the room and say, oh, should I drink or should I not drink? So is the answer yes or no? What do you all think? If it is yes or no, any signs you want to show? Yeah, that's right. So we'll go into the details of why we say yes to it as well. And in the risk drinking, there is an increase with hypoglycemia. Is it true? Right. And then hyperglycemia. That's also correct. Liver disease. Yep, that's also correct. Obesity, high blood pressure, and stroke. So we can't ignore these, and these might be getting escalated if the person is having a risk behavior with drinking. So if we think, yes, these are something that needs to be paid attention, and we look into the next slide. Thank you. So the first impact is about the carbohydrate. We call the carbohydrates and the alcohol as liquid carbohydrates. And in these carbohydrates, if the person has occasional drink and he has got a consumption of a food in combination, it is better. And the meal has to be a complex carbohydrate with a protein and a bit of a fat that will slow down the digestion of the liquid carbohydrate. Because we know that liquid carbohydrate, it can metabolize very quickly. And it's very important to remember that please eat your carbs when we have a consumption of alcohol. And I just put a plating of portion sizes, just sharing about different meals that we can think about. And liquid carbohydrate has got lots of other impacts. As we go into the next slide, we'll discuss a bit. Thank you. So when it comes to the carbohydrate, to prevent either it's a hyperglycemia or hypoglycemic effect, it starts with what is my blood glucose usually before the meal time, what is a meal I'm planning to eat, and what is the type of medication I'm actually taking for my care. And when we look into the alcohol, that's not impact just then. It can also have an impact up to 16 hours after you finish the last sip of the drink. And if it is an empty stomach a person is having, it's very important to remind them that please have a snack before the bed. And next day morning, because as I said, the impact will vary from individual to individual, we also encourage them not to skip the breakfast. If they have to get to do things and driving and stuff as well, it's very important. And if they would like to have some combination of a cereal and a toast, again, having a good protein, like some egg with it, or maybe some avocado on toast, simple, is also better than missing or skipping a meal. Then if we look into the impact of these calories as a second topic, so we know that excess of calories accumulate into fat. Over time, it causes insulin resistance, and that causes the increase in blood glucose that is leading to the fatty liver disease. So if we look into the chain of alcohol absorption, what happens? It just directly gets from stomach into the small intestine to delivered into the liver. And the liver in general is supposed to going to the conversion of glycogen and glucose metabolism. That hepatic gluconeogenesis means generating glucose from new sources has been all interfered. And that impacts again the blood glucose. So medications also are metabolized in the liver. The ethanol from the alcohol also gets metabolized in the liver. And the empty calories are also causing a bit of a functional challenge with the liver. So we know already the pancreatic function is challenged with blood glucose and diabetes. On top of it, there is a load on the liver, makes the situation a bit more hard to deal with. So this is just giving you an idea about the 2024 diabetes type 2 drug classification comparison. I think most of us are aware of these drugs. And if we look into the mechanism of action, some work on the liver function, some directly on our blood glucose, some on the kidney. And of all these drugs, there are only few that interact directly with the alcohol. So if we look into the semaglutides, they are causing a bit of challenge because more and more people we see are on these injections these days. And we know the main impact of that is slowing the gastric emptying time. And they feel like I'm not hungry. And then they will start having the drink and they're missing the meal. And that's the most very interesting thing that we need to work hard to tell them that please don't stop eating. It's the amount of alcohol that matters. So they have to watch the amount of alcohol they're having and make sure they also consider eating the meal, because the impact of that interaction with the drug and alcohol is increase in triglycerides, neuropathic changes, and also the pancreatitis. And with the medications, metformin has been well known to be misused with alcohol, causing lactic acidosis. So it's very important. We know that metformin clearly states, please you eat and have metformin together in most combinations, which is a quick acting. So people will think like, oh, I have to take my metformin before I go for my drinks with my friends, and then they will not eat. That's when there is a risk of this, and it's more important to educate patients about it as well. And in case of insulin, it depends on the type of insulin the person is on. And if it is not balanced properly, it might even cause hypo or hyper. It can do on either sides of the reaction to happen as a cause of impact. And chloropromide is like a disulfiramide reactions wherein the person can feel like flushing, headaches, and nausea. So these are the main medications that we try to work around with the clients to make sure we are educating them about it. And if you want to have more information, it's always, they have a choice to talk to the pharmacist, they talk to the doctor about it. And there is a website wherein it talks about, can you check the interactions? And it's just a WebMed site there for the details to go through. Next one, please. So in summary, we don't want anyone to have excess alcohol, and all medications interact with alcohol. The best type of alcohol, if someone asks me, I usually say, go for the one that has got lower sugar or the carb content, and limit drink with high or sugar sweetened wines and liquids. And if the diabetes treatment by insulin or certain tablets can cause too low or too high, be prepared with the hypomanagement as well. And it's good to have some type of identity or a medical tag when you're not dining with the family who knows that we have diabetes as a challenge to handle. And everywhere it's important. In my room, I just try to place this information that don't have alcohol and metformin, because most people ignore the small message. And if there is a um, B12 deficiency, very often combination with these medications, it's because of the excess of urinary output with the alcohol dehydration related. B complex is water soluble and it goes away in the urine. So it's better to keep an attention of these other parameters. And lactic acidosis is something, if we can educate the symptoms, it also benefits everyone. Next one, please. So it's all drinking is individualized. There is no universal rule. Take time to think. Safe choices are very much important when we are living with diabetes. And thank you all, chairs, for listening to me. So I think that's all good for today. Thank you.
Thanks, Naduri. We'll just ask the audience if they had any questions about the didactic presentation tonight. You can either type in the chat or turn on your microphone and ask Naduri.
Thank you, Mani.
I have one which you maybe Manny might be able to answer. It's just about the interactions between the GLP-1 and alcohol, and you mentioned neuropathy and triglycerides as one. Maybe it might be one to palm off to Manny, but I just thought that was quite interesting because I thought alcohol in and of itself caused those issues particularly. So I just wasn't sure if it was perhaps due to even more of a vitamin restriction when on those agents, or if there's actually a drug-drug interaction there.
Yeah, so I thought that was interesting as well. I'm not aware of a specific peripheral neuropathy related to GLP-1 receptor agonists. The mechanism that I could sort of consider is that if you have a rapid weight loss due to any cause, you can end up with mononeuritis. So the typical one is a peroneal nerve palsy in the leg. And you can get those secondary to significant weight loss rapidly, and we don't know why that is. But we know alcohol can cause a peripheral neuropathy, which tends to be bilateral, symmetrical, length dependent, similar to a diabetic neuropathy. But I don't know specifically of a neuropathy that is associated with GLP-1 receptor agonists and alcohol. Interestingly, I mean, there is some data to suggest that GLP-1 or incretin analogs in general can reduce alcohol intake. So I think a GLP-1 or something like tirzepatide would actually be a really good option for someone who's drinking excess alcohol in an attempt to try and reduce their alcohol intake. And similarly, a lot of the comorbidities that patients with alcohol excess have, such as hypertension, hypercholesterolemia, hypertriglyceridemia, as we just discussed, obesity, metabolic associated fatty liver disease, all of those things respond really well to the incretin analogs. So I would actually think that that's a very useful class to use in this cohort. In terms of triglycerides, again, I'm not aware of hypertriglyceridemia being caused by that combination. Certainly, alcohol excess does drive through the same metabolic pathways in type 2 diabetes, hypertriglyceridemia. But again, I've only seen triglycerides improving on incretin analogs, even in people who drink alcohol in excess. So I wouldn't avoid that class of medications in people who drink excess alcohol. Certainly pancreatitis is a contraindication. If they've had pancreatitis once, I wouldn't give them an incretin analog. And certainly if they're drinking excess alcohol, their pre-test probability is high. So I would have a very sensitive conversation with the patient And if they truly were willing to cut back on the alcohol and hadn't had pancreatitis before, I would still try to get them on a GLP-1 just because the benefits are so absolutely great.
Thanks very much, mate. Really great answer. Appreciate it. Any other questions before we move on to the case presentation for tonight? With that, a very big thank you to Marjorie for a really interesting presentation and a very salient reminder that alcohol intake is a critical issue for our people living with diabetes and something we should be asking about regularly. Thank you.
Thank
So
you all
we'll
for
pass on.
listening. Thank you.
So
Thanks, Wendy, for the great presentation of this very complex case from southwestern New South Wales. If anyone hasn't done it yet, please Google where Wendy's located and just see the isolation and remoteness that she's been talking about. So she presented a 69-year-old Aboriginal female who has a history of suicidal indications resulting from the murder of a child and domestic violence issues. The patient turns to food to help manage this. There's a lot of limitations to her treatment. For example, transport to services and lack of services in their health district. Patients had a really good result recently with reducing a HbA1c from 14 down to about 6.7%. Patient has started walking. And she's got an interest in going to the motorbikes. She started walking, but she walks to go and get food. Some psychosocial support has helped. This patient has a cycle of ups and downs. She goes really well and improves with her diet and exercise, but then comes crashing down when there might be some pressure coming from home. Has a great rapport with her health team, but some of the local health professionals are feeling a little bit overwhelmed and might be a little bit out of the depth to provide the care that is needed. Patient is aware of online services. Manik made a great point of do we treat the mental health to help all aspects of her health, or do we treat each modality individually? Has demonstrated that she can improve her health, for example, by drastically improving her HbA1c. As health professionals, we have a role to play to continue to encourage improvement. Now, with the management, once again, we kept coming back to the limitations of the services in the area and transport to get services, cost of living, things like that. But telehealth is a great service now. So looking at telehealth consults with psychiatrists, integrated team care referral to help cover costs. There was Manik and Alex both talked about getting away from glycoside and getting back onto metformin for many reasons. Just trying to access mental health services via telehealth, Strong Mind Western, victim services, 13 Yarn, first responder specific support. Other suggestions were improving her social network outside of her family. And another strong recommendation from Alex and Manik was to make sure she has a medication review as soon as possible. Thanks, Wendy.
thank you, Tim, and thanks, Wendy, for such a interesting, challenging case and for all the support that you're giving this woman. I'm sure it's greatly appreciated. Last bit of advice I'd say is that a lot of people with mental health problems don't expect you to fix their problems. They're just happy to have you there with them. And it sounds like you are truly there with her, and that makes a world of difference. So up on our screen right now is our evaluation form for tonight. You can scan it with your phone. It will take you through to the link and you can fill out your evaluation. Next slide, please. Oh yeah, and so our next session will be on 14th of November, 1 month from today. Amanda Taylor joining us tonight with some fantastic commentary, will present on technology used in the management of type 2 diabetes. And you'll have to wait until then to find out what our final topic for the year will be. And lastly, reminder that Health Pathways exists in Western New South Wales. It's fantastic. It's got lots of information about various conditions that clinicians may not know how to get appropriate help or supports. And as you can see there on the right side of the screen, it says mental health support requests. So it's got some great ideas as well there as to how you might access supports in your region, Western New South Wales. Far West also has a Health Pathways. Unfortunately, I'm not quite sure where they're up to there with that one, but you guys are still welcome to join Western New South Wales. It's also got local clinician editors who are contributing and updating the pages every week. So highly encourage you to have a look. Lastly, thanks for your joining tonight. We understand that it may raise issues for you personally or for your clients, and we take a lot of burden on from our clients. Sorry, Ali, you've lost the slide there. Thank you. So if any of the content tonight has impacted on your well-being, please contact 1-800-RESPECT for domestic violence, mental health line on 1-800-011-511, or Lifeline on 13 11 14. Thanks very much.